Hello, welcome to the presentation section on association analysis, exploration, and modeling. Let's cover some of the data activities that were particular to association analysis. In order to perform association analysis in Enterprise Miner, the data must be in the form of a transaction data set. So we had to convert the data from one record with up to 25 diagnoses to 25 records, an ID and a diagnosis for each one, a transaction data set. We also had to consider the taxonomy involved with digestive diseases and their diagnosis. We'll go into that in more detail in the next slide. For data cleaning, while there may be missing values at the end of the diagnosis chain, for instance, if you only had a primary diagnosis, you wouldn't have a secondary through number 25 diagnosis. Those missing values shouldn't be replaced. When the data is transformed into a transaction data set, there will be one record with the one diagnosis as it should be, and that's correct. HCUP, which provides the data, does some cleaning and integration of data from the different states that participate. And if an ICD-9 diagnostic classification code is invalid, they will replace that invalid code with the special missing symbol invalid. During the creation of the rules, the invalids were so few that they never came up in the rule set, so they were not a problem. We didn't have to remove them. They just weren't part of the rules results. For data reduction, we limited the records, the individual discharges, to those that had a diagnosis of IBD disease, which is Crohn's or colitis, or irritable bowel syndrome in any one of their diagnosis fields 1 through 25. We'll cover things like lessons learned. As I said, we'll look at the taxonomy now. So let's go ahead and get started. For digestive diseases, all the diseases we're considering fall into digestive diseases. What did we learn from association? They have their commonalities. Well, same sort of conditions. Trade-off between problems with bowel movements, too few, too many, and the minimum metric levels. But if we go down a step lower, we see that there's IBD, which is inflammatory bowel disease. Let me give an example. And irritable bowel syndrome. You set your granularity high, and then there are two types of IBD disease. There's Crohn's disease, set your metric levels, and there's colitis, a little bit higher. Now, each one of these diseases has one ICD-9 classification codes, but if you had your granularities of a special form, for Crohn's it's the number 555 followed by a dot, so you might end up setting your, for colitis it's 556 followed by a dot. So that's how we identify the other value. It's as how having either Crohn's or colitis by the ICD-9 codes. So it makes it harder to be objective in deciding transaction data set. IBS only has one ICD-9 code associated with domain expertise, and that's about your subject 5.6.1. That seems like a reasonable rule. Or that's doing the initial exploration and the trying out of association analysis, creating rules. It doesn't seem to have what the parameters should be, what relationship should be. We tried different levels of granularity analysis. And we tried using IBD, but that was too high a level. All the Crohn's and colitis rules with Enterprise Miner they weren't individually sorted. They were all under IBD. The actual association analysis model value or not, and that wouldn't let us tell test sets find the differences between Crohn's and colitis patients for that process to occur. And on the other hand, going down to the level of the ICD-9 codes, we didn't find a lot of support for individual ICD-9 codes. There will only be two records. You've got to know a little bit about two rule results that would appear if we use the ICD-9 level or not. So the level that was chosen was to use
skin disorders.
Crohn's disease, colitis, flags. If a person had
also that
Crohn's or
domain
colitis,
expertise is valuable for text mining.
we would substitute all the ICD-9 555s with a CD
related text to that. It's helpful
text
to know
string or a
what words
UC
need to go
text
together
string,
in
so that
phrases, so that it's
we'd be interested in
really a
rules
phrase
that
is 1
said
minute.
if you have this condition,
And that you need some more domain
then
expertise
the right
and
hand,
at
and the
least
right hand
some
side of the
knowledge
rule,
medical
then you have
terminology
UC.
in order to
So
set
let's get into the
quoted.
modeling a little bit, and I think it'll become clear.
Also for text
To
mining,
start the modeling, we
expected to
partitioned the
see
data
more,
that we had
I'll call them
into
homogeneous
train,
clusters.
validate, and
We expected
test.
clusters that
40
would be
each for train and validate, and
97%
20% for test.
UC patients, and another cluster.
We considered
90%
what
CD
values to
and
use
another
for the
cluster,
parameters.
IBS patients.
In enterprise
But
mining, you
that's
have to
not
set
what
the
happened.
minimum
We did have
levels
clusters that
for
were
confidence and
85
support.
to 90% UC or
To
CD.
try to get an
But then we
idea
had
of what's
quite
been
a
used
number of
before,
other
we looked
clusters
into
where it
the
seemed that
medical
the
literature
definition
and
was
found an article by Yang and
what
Logan,
did they have
who
in common
also
while they
did
were admitted for
association
diabetes,
modeling on hospital
or because they were
discharges.
pregnant, and
They were
they
looking at a
also
particular
happened to
type of
have
hernia.
a chronic
The
condition,
confidence level they used was 50%
IBS,
with a support
CD
of
or UC.
0.06.
So
We
the
tried those
clusters came
values
out
initially, but we weren't getting
differently
very
than we
many rule
expected,
results.
but
And
it
we
was still
saw
very
that
useful
the rules that
information
were
and very
appearing
usable
did seem to be
for
relevant
our
at the
analysis.
50%.
We
So
did
we
find with the
lowered the
expectation
minimum
maximization
confidence
clusters,
level
they
to
were
35%,
13,
examined the
14,
rules that
12,
were
and
being
4.
generated, and saw
Usually
that
the
they
primary
were
reason for admittance
at least
was
reasonable
Crohn's disease
on
or
initial
ulcerative colitis.
observation.
And we
There were
saw
still
with those
digestive
clusters
diseases,
that the other
or
conditions in
consequently
that
related
cluster,
malabsorption
in that
problems
cluster
that were
would be
coming up with the rules. So we
blood
decided
loss,
to
hemorrhage,
try these
anemia,
confidence and
abscess, and
support
fistula,
levels.
which are very much
The rules that we are going to look at are
expected
those with
or
CD, UC, or
unfortunately
IBS on the
occur
right-hand
often
side,
with
and
CD
we will
or
consider the
UC.
support value. We've already limited the
We
data
found
that
those
we're
other
looking at to
clusters
those
that I
people
mentioned
who had
before,
either
where
IBD or
primarily
IBS.
the patients had
Not looking
diabetes.
at all
They
3
may also
million
have
records.
UC or
We're looking at
CD, but there
about
was quite
17,000.
more heterogeneous blend of patients.
So let's see what happened next. Well, we ran the
with
models,
IBS,
and
well,
we
IBS
looked
was
at
not
results
often a
that
primary or
occurred
secondary
in
diagnosis.
both the train and
So
the
we
validate
didn't really
data
find a
sets.
cluster that was mostly
And
IBS
notice I didn't say
patients.
test. The test data set with only
So there in
20%
text
of the
mining, we
data
didn't get
was not
as
returning
much
very many
information as we did
rules,
with association analysis.
because I guess
about
if you
IBS.
have a condition that doesn't occur very often and it's not in your 20%
which
of
is
the data,
kind of
it's not
models
gonna
the
appear
real
in the
world.
rules.
IBS is
So we looked at rules that appeared
a
in both
diagnosis
train
that's
and
made
validate,
after they've ruled other things
so that we would have
and they can't find
some,
a structural
I
problem
want to say validation, some
that's causing the digestive diseases. It's a
consensus
functional
about
disease.
rules that would be valid for the data in general,
along
not
with
just this
the
particular
saying
train
that the
sample or
domain
validate
expertise
sample,
was
but
needed,
both of
what we
those
did was we
samples.
went and looked at patient
And we'll
information
cover a little
that's
bit more of
readily
those issues
available
in
from
the wrap-up
different
section of the
foundations
video.
geared toward helping patients with the different
Now, from the
diseases.
results
or
of
Crohn's and colitis,
the association analysis modeling,
CCFA,
we took
Crohn's
those
and Colitis
conditions that
Foundation
appeared
of
on the
America,
left-hand
and
side
IBS, sorry,
and
I don't
used
remember
those
the name.
later
It's
in
our
predictive
written
modeling to
paper
create
as a
predictive
model.
reference where
There's
the
a patient
target would be
information
Crohn's disease,
website for
colitis,
IBS. So we
or
went out
irritable bowel.
and found
Here's the enterprise minor
what
implementation.
typically what a patient
looks
or
pretty
their family
complicated.
would know
It is
as conditions
because
associated
enterprise minor
disease.
association notes will
So let's talk
accept
a
as
little bit more
input
about the
different
comparison of the
partitions,
association
train, validate, and test.
mining
But it'll only
results.
run the modeling on the train.
Found there's no
So in
there's no
order
metric,
to
there's no single
run the
stat to
association
say,
analysis
well,
on the
here's
different partitions,
association analysis rules.
I
and
created some
here's
SAS
the text mining
code
clusters
that made enterprise
mining,
miners
and,
think
compared
that it was
the two,
getting
and
training
say one's higher than the other. That
data
doesn't happen
when
that way with association
in actuality
analysis
it was
and
getting
text
our separated
So we've
train,
kinda
validate,
taken
and
more
test. So I flipped a
complementary
bit to say that this is really
what
training
information
data.
did we
Please
get
run
from
it.
association analysis and similar information?
So here we have the SAS code. Not really necessary
to
here
add
for
those
train, but
together and to
yes, it is
look
train.
at
We set the
outside
target
domain
variable.
knowledge and to see what was reasonable.
And then separately within
because
the association analysis
and
does
text
have
mining,
target
we also
variable.
did predictive modeling to
And then
look for
we run the association
variables.
node. We use SAS code
Association analysis was more
afterwards
for
to compare
classifying, and
the
then
rule results
the
from
text mining
the
was
train
more for
and validate
making
data
predictions
sets itself
and
based
tell
on
you variables.
about the results that we found. We look at the
More,
rules
a little bit more
individually,
about the
those
lessons
for
learned.
Crohn's disease. These
What
are
were
the top
common
10
findings
rules,
with text
and
mining
they
and
cover
association analysis.
broad
Ulcerative
body system
colitis,
categories
we found
here.
the blood loss, anemia,
Digestive
weight loss,
system,
dehydration,
just to be expected.
completely expected and
Also,
found in patient
blood
literature. The Crohn's
and
disease,
blood organs.
anemia, fistulas,
Here we see it's
hemorrhage,
anemia.
intestinal
Anemia
abscesses,
appears
and
several
obstructions.
times.
Also, all found in patient literature.
Endocrine, nutrition, metabolic.
Let's consider
those are due to
where we thought we were going to end up and where
folks
we
with
actually
Crohn's
ended
disease
up.
have problems absorbing
The
nutrients.
data that we
because
used
their
is the same
digestive
source,
system's
the
not
KID
working.
2009 data. And
We
each
see
cup.
that there are
We did create some
other
derived variables
conditions
along the
which
way
really is just
related
a
to
notation
the
that they've been taking steroids,
taxonomy, UC,
which
CG,
is
and
a
also
common
the
older
codes creating flags. Did this person
pharmaceutical
have this particular disease?
prescription for Crohn's
had
disease
to-
or ulcerative colitis
in text
is
mining, we
prednisone.
recoded,
We have a note
reformatted
that
from the
that there
ICD-9
were
codes to actual text phrases.
children.
And we did some
They're
grouping of
pediatric
the
were using
codes.
some of
Tobacco.
the all
You can take a look at the
555
top 10 rules
ICD-9
for
codes.
ulcerative
We're going
colitis. Use the
We
level
see
of
a similar
saying
group
all
of
those
rules.
codes. That's Crohn's. And we're going to
Digestive system,
all those
blood,
individual codes with
metabolism, nutrition,
Crohn's disease.
use of steroids. We also see
Now, in our original asthma,
write-up, we had an objective,
and
and
in
here we
that
see
objective, we said we would look for
known
conditions,
conditions,
which is blood and
known
stool relationships. Known wasn't really specified enough.
So really,
what's known?
rules
Who
that
knows it?
we
Depends on
expected
who
to
you
find
are.
for the most part.
So we ended up doing literature searches of that patient literature.
For IBS,
And we identified
known
reflux
as
as
the
those
highest
conditions that
support.
were found in patient literature,
Then we have asthma,
as opposed to
respiratory
conditions maybe
Then we have
that gastroenterologists,
diseases
pediatric
of the
specialists
digestive
would
system,
know or expect to see.
metabolic
as a
again,
condition on a
dehydration.
Crohn's
If you have
discharge.
diarrhea, you probably
So
will
we
have
performed
dehydration.
literature
and
searches
some mental
with
health
patient
disorders.
information and in more sophisticated medical
Those are just the
research
top
results.
10. There were many more rules that appear in the appendix.
Also
and are
with the
written
known,
report.
it's all tied in there. What does known mean?
So now,
Is it
taking
supervised or
the
unsupervised?
left-hand
Well,
sides of the rules,
really, if it's going to be known,
we
it's
created
more
derived
supervised
variables, which were of the form, which were flags.
that
Did
occurs
this person
afterwards
have
when we're
weight
looking
loss
at
or not? The 0 or 1 flag.
the results from the association
The name of
analysis
those
text.
variables were changed
Does it
to
seem
C
reasonable?
and the ICD-9
Now, if you're
code. just to
searching
try to
for
keep
unknown,
track.
well, then
be able to map
that's
back
not going to
and
be
forth.
supervised, and that's how we're deciding
So what we did
who's the
is we
what conditions are
set
unknown.
3 different target variables.
And we decided
and
along
ran
the way
models 3
to add
different
in
times.
predictive modeling
The
to predict
enterprise
those
minor
targets in both
flow diagram
association and text mining
is pretty
analysis.
much the same for all the models.
Also,
Except
issues
of course we would have
involving
different data and
scope as far as
different
symptoms and
target
conditions, the taxonomy. What you decide is
So what was
what
used
level do we
as the
model
independent
disease
variables, you ask?
or
Well, we used the demographic
IBD
variables
in
from the
general.
data, age, gender,
and that scope
those
also
derived
came into play when you're
ICD-9
looking at the left-hand
variables,
side of the
and
wheel.
also variables
There are
that
many different types of
H
anemia.
cup
Do we model them
creates
each
called
separately,
comorbidities.
or
H cup
include them
has
together?
software that will look
we ended
at
up modeling them
all the
separately
diagnosis codes
because anemia
for
could
a record
be due to blood loss
and
as
set
well as
flags,
non-absorbing.
flag variables similar to the
What
ones
are
I described. It will set
impacts of
flag
medications?
variables
Well,
to
some of the
say this
medications
person
you
has
take
diabetes or does
for
not
IBD
have
diseases
diabetes. So we used the
cause some of the
comorbidities that
conditions
were
that
not
you see. So do you say,
that
well,
were not
if you've got
overlaps of the ICD-9 codes that we were looking at.
low
So we didn't
potassium,
use the
let's say,
anemias. We used our specific
is that
ICD-9
because you have
codes.
IBD, or is that because you
for
take a medication
the
that
anemias.
causes low potassium? The same with
All right,
disease
let's take a look
severity.
at what I was saying before with the data. Now we set the
Disease
target
severity and what
variables.
conditions you
Did
have
modeling 3
for
different times.
inflammatory bowel disease.
We
There's
set the target
relationship
variables to UC or CD
there.
or
More severe
IBS.
cases will have,
But
we've
we've so far limited
dehydration, and that
the
might bring
data
you
to
the
only
hospital.
those records that where
But
someone
as you go
had
on,
a
you have
diagnosis.
more absorption
what
problems,
We've done is we've
more
pulled in data
imbalances in your
from
blood.
the original data
You may
set
end up
that
with
did for
conditions
folks who did
like
not have these
tachycardia or
diagnoses
liver
on the
issues.
discharge. Used the sampling
Let's
and stratified
talk about the
sampling so
results
that
that
we
we
could
found.
have
We
50%
found that there were
yes
common
target
symptoms.
for
Well, let's
UC
stop
and then
and read
50% no,
objectives.
they did not have
We're
UC.
going to determine
We used
which
the
other
partition
ailments
node
are
again to
closely
separate
associated
into
with
training and
IBD.
test.
I believe we did that.
Validation
plan to
also.
discover how groups
And
of
as I said,
IBD
we derived
patients
variables
are
for
alike
the
and different.
ICD-9 codes that came
And
out
we
on the
further hope
left-hand
to
side
discover
from
how groups of
association
IBD
analysis.
and IBP
Renamed
IBS
them
patients are
C
different
and then the code
to
number
develop
so that
a
we have a map
diagnosis
back
process
process.
that will better differentiate the two.
We used the demographic variables.
So let's cover
We
the
also
common
included a
symptoms.
severity variable,
We've
which is
discussed those
a
before.
range
Those are all
indicates
the
which stage of the
digestive
disease you're
disorder
at.
and associated
With
weight
the
loss symptoms. Then we had
higher level
symptoms that were
numbers
common
being
that
more
were not
severe
in the patient literature, the gastritis,
stage of the
reflux, and
disease.
asthma.
And as I said, we used the HCUP comorbidity.
Those were
variables.
common for all three, CD, UC, and IBS.
So if we look at the results of our
Then we can
predictive
look
modeling,
Crohn's disease in
and we
particular
see
is
we use
characterized
the
by abscesses,
tree, gradient
fistulas,
boosting,
fissures, and
logistic
intestinal
regression, and
obstructions,
MBR,
UC,
which is
hemorrhaging,
K nearest neighbors and
cholangitis,
enterprise minor.
C. diff, pancreatitis,
And we selected the model by the test misclassification
So
rate.
let's see, did we
So we
find
selected
groups
the
of
model with
patients
the
that were
best
alike or different?
misclassification rate.
Yes, we did, because
Which is
CD patients tend to have those
27%
abscesses
with
and
the tree.
fistulas, and UC patients have
Not
a lot
a
more
textbook amount,
bleeding
but
and liver
it-
and
diagnoses are very
with
hard
more
to make
severe cases,
in person when
tachycardia
you're an expert.
issues.
So it's really not surprising that
We also found
this
IBS
analysis with
patients tended
association
to have
analysis
headaches
predictive
or
modeling
migraines
came up with
on their
30%,
discharge
27%
records.
misclassification rate. We look
And
at the tree
comparing
output, we find that the
IBD
important
and
variables
IBS. What's the difference?
for
Well, they all have
age,
those
the
common
disease
digestive
staging,
symptoms and
gender,
pain.
along with
The
ICD-9
difference seems to be
codes,
those
indications
malabsorption
of anemia,
problems.
pancreatitis,
The anemia
due to hemorrhage, and
all those blood
dehydration.
electrolyte type problems.
Next, we'll look
But
at
if
the
you've
results of the
got
predictive models for
abdominal
ulcerative
symptoms,
colitis.
digestive symptoms that are going
You
for
see
a
our
while,
UC model
and your blood
assessment
work
again.
was also coming out abnormal.
And again, the
Doctors
tree
should consider
has the best
having
test
the patient evaluated
misclassification
for
rate,
an
about
inflammatory bowel disease.
28%. The important variables
And
here
of course,
are
if they have any of the CD
age,
or UC particular
disease
conditions,
staging.
bleeding, abscesses, they should
This
definitely
is
be
one of the
evaluated
comorbidity
for
measures
IBD
that
versus
relates
IBS.
to electrolytes. Dehydration
So we
generally
said our
will fall
objective,
under
we would
the
have been
electrolytes. There
successful
are other
if known related
ICD-9
diagnoses
codes that
are
we looked at
verified, and
electrolytes
two or more unknown relationships
for a more
are
general
found.
level.
So did we find known
And
related
you can see that
diagnoses?
there
Yes,
are
very much so.
about
All of
6
the common
derived variables
symptoms
that are
and
related
those
to ICD-9
symptoms in
codes.
particular for UC and
Find
CD.
blood in the stool, iron
So
deficiency
it
anemia,
seems that
due to blood
association
loss,
analysis and
cholangitis,
text mining
which is
are providing
a disease related
fairly
to the liver ducts inside the liver.
explainable results. I'm not finding
The
inexplicable
electrolyte disorders I mentioned before, asthma,
but that does
another
bring us to
anemia,
the unknown
unspecified,
relationships. How do you define
iron
unknown?
deficiency anemia,
Well,
and
we decided to
intestinal
look at it and
infection
say,
due to
well, if a patient
we'll
or
call
their
it C.
family
diff,
could
it's
find out about it
particular
from
to the
reputable
colon.
sources, that's going to be a known relationship. And we're going to consider those
The next predictive
that are
modeling we'll look at
those conditions that
is
involve other
the
organs,
IBS
like
model
the
assessment.
heart or the liver,
Again, we
to
see
be
the tree
a
model
type of unknown.
had the best
Now we found
misclassification
that
rate.
tachycardia,
0.29.
cholangitis, and pancreatitis have been
The
the
important
subject
variables
of
were
research
age,
studies about IBD and
gender,
their
disease
relationship
staging.
to those diseases, and
They
they
have a
been
comorbidity
verified
of
in
drug use.
research literature.
and
So
for the
if you were
ICD-9 codes, we
pediatric
see
gastroenterologist, you could look
reflux
at our
in the esophagus
results
and functional
as far
digestive
as rules
disorders.
and say, well, yes, there is a relationship between tachycardia and
means that your digestive system
What
is
other
having trouble
unknown
functioning.
inexplicable
Okay, that's a little
relationships did we find?
circular,
We
but it
had
means there's no
reflux,
structural
gastritis, and
problem that they
asthma.
can find. You're having
Now,
you're having
we have
digestive
found some
problems,
medical research papers
but the
that
cause
actually
is
study those more.
how your
actually study those,
digestion
let's say.
and elimination
But there
is
wasn't
actually
a
functioning,
consensus
and not in
among the papers whether there's
bleeding
a definite
restrictors,
relationship
those kind of
between
issues.
reflux,
So we can see that
gastritis, asthma, and IBD or
important
IBS.
variables for
So really, those are
Crohn's
our
and
unknown
colitis
relationships that we would advocate
had
there to
quite
be
a bit of
more
overlap,
hypothesis-based testing,
and those
or
for
to
IBS
have a study where you can
outside
go
of
and
I'm not
check
talking
the
about
medical
the
records and
demographic
see if
variables.
people
The
came
ICD-9
in
codes.
with
The ICD-9
reflux,
codes for
gastritis, and
IBS
asthma,
are different.
or if they developed them while they were in the hospital, so we
Now,
can see if there's a confounding influence there.
It's medical information.
So were we
healthcare
successful? Yes, we did
information.
find known
It's difficult to
relationships,
deal with.
and we have our two types of unknown
Really,
relationships.
the way
those
we're modeling
that
it is
a
sort of
medical professional in the
unsupervised,
field would verify
but we
and
have
assess and
more
say
domain
yes,
knowledge.
but
There is a
an
way
ordinary
to look
patient
at this
may
as
not
a
know about.
supervised problem.
And then we have our unknown relationships
What we
that
can
are
do
really
is
still
go out
under
and look at the
investigation
patient
by
information
medical
that's
researchers,
available
and we would
about each of
advocate
these
further
diseases
studies.
and verify some
Thank
of the
you very
rules that we
much.
found, all the rules that we found. And we can, if we find a rule that is surprising, we can look into it further and go past that level of just what does an ordinary patient have access to. And we'll discuss that in the end of the summary with our objectives. So let's review. What are common symptoms for all three of the digestive diseases? Abdominal pain, fever, fatigue, diarrhea, nausea, vomiting, dehydration, and weight loss. We also found gastritis, reflux, and asthma common to all the rule results for all three of the diseases. And those are not documented in the patient information. So that may be an area that we can look into and advocate for having hypothesis, more strict medical studies performed to see what is the relationship between those three, gastritis, reflux, and asthma with IBD. Is it just that if you're in the hospital with a digestive disease, maybe you're laying down and you're getting gastritis because you're laying down, or reflux because you're laying down, or you're not getting out of the bed and you're developing wheezing? It's difficult at this level to say that, oh, well, of course they're going along with IBD or IBS. It's something that we've got to explore these further. So those are the common rules, common left-hand sides for all the diseases. The first bullet are known symptoms, conditions for all three of them. The second bullet we'll say, well, they're not known. They were surprising. Now, if we look at what UC and CD had in common, was all those malabsorption type diseases or conditions. The anemias, the low potassium. We have an excellent reference in our paper that Dr. Huang, I think is the pronunciation, that discusses why these happen in people with IBD and not IBS. IBD is an overall inflammation disease. If your digestive system is not functioning and it's hard to absorb nutrients, or you may not have a lot of your digestive system left in order to absorb nutrients. In addition, some of the medications that treat IBD, immunosuppressants and other types of medications, cause you to lose some nutrients or minerals. So that's a differentiating factor between IBD and IBS, is the problem of malabsorption or loss of minerals, anemias, or iron, etc. So let's look at how you differentiate between Crohn's disease and ulcerative colitis. Now, so they have, beginning to level, they have the common symptoms, they have the IBD symptoms, but Crohn's disease, we also see abscesses, fistulas, fissures, and intestinal obstructions. And with UC, we see the common symptoms, the IBD symptoms, and hemorrhaging, the cholangitis, the C. diff, pancreatitis, and tachycardia. So we've gotten quite a bit of information using association analysis. And we can look at the rules that came out, the differences in the patient groups, who has CD, who has UC, and what the different left-hand sides or conditions were that resulted. And the next step we'll be looking at text mining and seeing how text mining results differ from association analysis. Thank you very much. Hello, in this section we will give a summary of our project and presentation. We'll cover things like lessons learned. Did we meet our objectives? So let's go ahead and get started. Let's start with lessons learned. What did we learn from association analysis? Well, found that there's a trade-off between the granularity you set in your taxonomy and the minimum metric levels, support, and confidence that you choose in your model. Let me give an example. If you set your granularity high, so if we had gone with IBD, you can set your metric levels a little bit higher. Maybe you want to have a 1 for support minimum. But if you had your granularities a lot finer, and then you wouldn't get very many rules with that one. So you might end up setting your metric level to 0.3. So you can't just look at one or the other value. It's how they work together. And so it makes it harder to be objective in deciding, oh, this is a good rule or this is not a good rule. So you need some domain expertise about your subject to say, that seems like a reasonable rule, or that's an inexplicable rule. That's something we didn't expect to find, and doesn't seem to have any relationship out in reality. So there's a trade-off with association analysis and your modeling of granularity and the metric levels you set, minimum metric levels you set. Also, we found with Enterprise Miner, it would not run the actual association analysis modeling the validation and test sets, so we had to create our own workaround for that process to occur. And as I said, without domain knowledge, it's hard to evaluate the results from your association analysis. You've got to know a little bit about the diseases you're looking at to say, well, that seems reasonable or not. You wouldn't expect to see a lot of skin disorders when we're looking for digestive diseases. So, and also that domain expertise is valuable for text mining. Text mining we used, instead of the ICD-9 codes, the related text to that. And it's helpful to know what words need to go together in phrases so that it's really a phrase is one unit. And that you need some more domain expertise and at least some knowledge of the medical terminology in order to set what's a phrase, what's a word. And also for text mining, we expected to see more, I'll call them homogeneous clusters. We expected clusters that would be 90-some% UC patients, and another cluster 90% CD, and another cluster IBS patients. But that's not what happened. We did have clusters that were 85 to 90% UC or CD. But then we had quite a number of other clusters where it seemed the definition was, what did they have in common? Well, they were admitted for diabetes or because they were pregnant, and they also happened to have a chronic condition, IBS, CD, or UC. So the clusters came out differently than we expected, but it was still very useful information and very usable for our analysis. We did find with the expectation maximization clusters, they were clusters 13, 14, 12, and 4. Usually the primary reason for admittance was Crohn's disease or ulcerative colitis. And we saw with those clusters that the other conditions in that cluster, for patients in that cluster, would be blood loss, hemorrhage, anemia, abscess, and fistula, which are very much expected or, unfortunately, occur often with CD or UC. And we found those other clusters that I mentioned before where primarily the patients had diabetes. They may also have UC or CD, but there was quite more heterogeneous blend of patients in there. And with IBS, well, IBS was not often a primary or secondary diagnosis, so we didn't really find a cluster that was mostly IBS patients. So there in text mining, we didn't get as much information as we did with association analysis about IBS. So, well, which is kind of models the real world. IBS is a diagnosis that's made after they've ruled other things out and they can't find a structural problem that's causing the digestive diseases. It's a functional disease. So, along with the saying that the domain expertise was needed, what we did was we went and looked at patient information that's readily available from different foundations geared toward helping patients with the different diseases. For Crohn's and colitis, it's the CCFA, Crohn's and Colitis Foundation of America, and IBS, sorry, I don't remember the name. It's in our written paper as a reference. There's a patient information website for IBS. So we went out and found typically what a patient or their family would know as conditions associated with that disease. So let's talk a little bit more about the comparison of the association analysis and text mining results. Found there's no metric, there's no single stat to say, well, here's association analysis rules and here's the text mining clusters, predictive modeling, and compare the two and you'd say one's higher than the other. And it doesn't happen that way with association analysis and text mining. So we've kind of taken more of a complementary approach. What information did we get from association analysis and similar information from text mining? To add those together and to look at the outside domain knowledge and to see what was reasonable. And then separately within the association analysis and text mining, we also did predictive modeling to look for important variables. Association analysis was more for classifying, and then the text mining was more for making a prediction itself based on the variables. So let's talk a little bit more about the lessons learned. What were the common findings with text mining and association analysis? For ulcerative colitis, we found the blood loss, anemia, weight loss, dehydration, completely expected and found in patient literature. For Crohn's disease, anemia, fistulas, hemorrhage, intestinal abscesses, and obstructions, also all found in patient literature. Let's consider where we thought we were going to end up and where we actually ended up. And the data that we used is the same source, the KID 2009 data from HCUP. We did create some derived variables along the way related to the taxonomy, UC, CD, and also the codes, creating flags. Did this person have this particular disease or not? We had to, in text mining, we recoded, reformatted from the ICD-9 codes to actual text phrases, and we did some grouping of the codes. Some of the all 555 ICD-9 codes were going to use the level of saying that all those codes, that's Crohn's, and we're going to replace all those individual codes with a code that means Crohn's disease. Now, in our original write-up, we had an objective, and in that objective we said we would look for known conditions or known relationships. Known wasn't really specified enough. What's known? Who knows it? Depends on who you are. So we ended up doing literature searches of that patient literature, and we identified known as those conditions that were found in patient literature, as opposed to conditions maybe that gastroenterologists, pediatric specialists would know or expect to see as a condition on a Crohn's discharge record. So we performed literature searches in both patient information and in more sophisticated medical research results. Also with the known, it's all tied in there. What does known mean? Is it supervised or unsupervised? Well, really if it's going to be known, it's more supervised learning. That occurs afterwards when we're looking at the results from the association analysis and text mining. Does it seem reasonable? Now, if you're searching for unknown, well, then it's not going to be supervised, and that's how we're deciding what conditions are unknown. And we decided along the way to add in predictive modeling to predict those targets in both association and text mix analysis. Also, issues involving scope as far as symptoms and conditions, the taxonomy. What do you decide is, what level do we model disease or IBD in general? And that scope also came into play when you're looking at the left-hand side of the rules. There are many different types of anemia. Do we model them each separately or include them together? We ended up modeling them separately because anemia could be due to blood loss as well as not absorbing. What are the impacts of medications? Well, some of the medications you take for IBD diseases cause some of the conditions that you see. So do you say, well, if you've got low potassium, let's say, is that because you have IBD, or is that because you take a medication that causes low potassium? The same with disease severity. Disease severity and what conditions you have for inflammatory bowel disease, there's a relationship there. The more severe cases will have, you may start out with dehydration and that might bring you to the hospital. But as you go on, you have more absorption problems, more imbalances in your blood. You may end up with conditions like tachycardia or liver issues. And let's talk about the results that we found. We found that there were common symptoms. Well, let's stop and read our objectives. We're going to determine which other ailments are closely associated with IBD. I believe we did that. We plan to discover how groups of IBD patients are alike and different. And we further hope to discover how groups of IBD and IBS patients are different to develop a diagnosis process that will better differentiate the two. So let's cover the common symptoms. We've discussed those before. Those are all the digestive disorder and associated weight loss symptoms. Then we had symptoms that were common that were not in the patient literature, the gastritis, reflux, and asthma. Those were common for all three, CD, UC, and IBS. Then we can look at Crohn's disease in particular was characterized by abscesses, fistulas, fissures, and intestinal obstructions. UC, hemorrhaging, cholangitis, C. diff, pancreatitis, and tachycardia. So let's see, did we find groups of patients that were alike or different? Yes, we did, because CD patients tend to have those abscesses and fistulas, and the UC patients have a lot more bleeding and liver and, with the more severe cases, tachycardia issues. We also found IBS patients tended to have headaches or migraines on their discharge records. And comparing IBD and IBS, what's the difference? Well, they all have those common digestive symptoms and pain. The difference seems to be those malabsorption problems. The anemias, the low potassium, all those blood electrolyte type of problems. That if you've got abdominal symptoms, digestive symptoms that are going for a while, and your blood work was also coming out abnormal, doctors should consider having the patient evaluated for an inflammatory bowel disease. And of course, if they have any of the CD or UC particular conditions, bleeding, abscesses, they should definitely be evaluated for IBD versus IBS. So we said our objective, we would have been successful if known related diagnoses are verified and two or more unknown relationships are found. So did we find known related diagnoses? Yes, very much so. All of the common symptoms and those symptoms in particular for UC and CD. So it seems that association analysis and text mining are providing fairly explainable results. I'm not finding inexplicable rules. But that does bring us to the unknown relationships. How do you define unknown? Well, we decided to look at it and say, well, if a patient or their family could find out about it from reputable sources, that's going to be a known relationship. And we're going to consider those conditions that involve other organs, like the heart or the liver, to be a type of unknown. Now, we found that tachycardia, cholangitis, and pancreatitis have been the subject of research studies about IBD and their relationship to those diseases, and they have been verified in research literature. So if you were a pediatric gastroenterologist, you could look at our results as far as rules and say, well, yes, there is a relationship between tachycardia and cholangitis. What other unknown or inexplicable relationships did we find? We had reflux, gastritis, and asthma. Now, we had found some medical research papers that actually studied those let's say. But there wasn't a consensus among the papers whether there's a definite relationship between reflux, gastritis, asthma, and IBD or IBS. So really, those are our unknown relationships that we would advocate there to be more hypothesis-based testing, or to have a study where you can go and check the medical records and see if people came in with reflux, gastritis, and asthma, or if they developed them while they were in the hospital, so we can see if there's a confounding influence there. So were we successful? Yes, we did find known relationships. We have our two types of unknown relationships, those that a medical professional in the field would verify and say yes, but an ordinary patient would not know about. And then we have our unknown relationships that are really still under investigation by medical researchers, and we would advocate further studies. Thank you very much.